Hi, I'm Dr. Michael DeTola, and I'd like to welcome you to this clinical presentation on the reverse preparation technique. This preparation technique that I'd like to share with you today was really kind of born out of frustration, and the frustration came from two places. My hands, my left and right hands, and I have a very average set of hands. And I learned this pretty early on in dental school when I was asked to come on the weekends and attend a remedial operative clinic. In fact, I think by definition, if you're asked to go to a remedial operative clinic, it stands to reason that you're not average, you're probably below average. So to call my hands average is probably an insult to actual average dentists. I just have to assume that I have below average hands, and I would see great preparations once I got out of dental school and began attending CE courses, and clinical mentors of mine like Bill Strupp and Bob Lowe. I would sit in the audience and look at the pictures of their preps and be totally impressed. And I knew what a great prep looked like, but I didn't know how to make these hands create that in a patient's mouth. And so my frustration level just continued to rise. And so I began to do research trying to find a way that I might be able to find a technique that was precise enough and that was accurate enough and that was predictable enough so I could get those kind of results on a day in, day out basis with this set of hands. And I've been able to do this, and I can't take sole credit for this. I got part of the technique from a 1940s prosthodontic textbook that I bought on eBay of all places, and some of the other stuff just came from research going through old Crown and Bridge textbooks and looking for what might make a system that would make it easy for me to get great results with average hands. It's called the reverse preparation technique because unlike in dental school where we were taught to prepare the rest of the tooth first and the gingival margin last, this starts off by prepping the gingival margin first. And so that really makes it easier to get a nice, uniform, clean margin. Very important to do because it's the one thing that assures that your laboratory is going to be able to give you a restoration that fits very well at the margin. In dental school, I was taught to prep the entire tooth and at the very end go and try to put a margin on this cylinder that I had prepped, and I just did not have the dexterity to do that. By prepping the gingival margin while the rest of the tooth's hard structures are still intact, and makes it much more easier to prep a margin at this point, much more predictable. And from the very first time I tried this technique, I saw that it was something special because I didn't wake up with a better set of hands. What I did do was wake up with a better technique. In fact, if I look back at the first 13 or 14 years that I practiced dentistry, I have to just conclude that I was a chronic under-prepper. In fact, when you see this technique, we'll look at the burr kit in just a moment, we have a way of using depth cuts. This is a depth cut based technique with some simple depth cuts. And one of the depth cuts that you place is a 2mm depth cut in the occlusal surface. This is the same 2 millimeters that every manufacturer of practically every dental material has been asking for. And I never gave it to the laboratory, and I could tell because when I started doing this prep technique, I would place a 2mm depth cut in the occlusal surface. I would prep the occlusal surface till I thought I was done, and invariably I still had half of that depth cut left. So I'd only prepped about 1 millimeter. It's no wonder that during the first 13 or 14 years of my career, I tried out 7 or 8 different dental labs. And frankly, I thought they all sucked. You know, as I look back at it now, all 7 or 8 of those dental labs had only one thing in common, and that was I was the dentist prepping the teeth and sending the impressions to them. Needless to say, now that I'm using this depth cut based preparation system, I no longer have that problems. I don't have the chicken scratch anatomy. I don't have opaque spots on anterior teeth showing through because I didn't prepare enough. Because I'm able to do things predictably and get a consistent amount of reduction, whether it's incisal reduction or occlusal reduction in the posterior. So let's go ahead and take a closer look at the burrs that are on the reverse preparation burr kit. Here is the reverse preparation burr kit, and as you can see, it's from Axis Dental. Axis makes it, the burrs puts it together, and it's sold through all dental dealers. It's called a Logic Set. It's LS7551, but I think everybody knows it as the reverse preparation kit. And let's take a closer look at some of the burrs on here. The first burr that we have on here is a 56 carbide burr. You know, you could use a 57 as well, and this is going to be used to break the contacts as we go through the first step, break the contacts, because as you'll see, it's critical that we get a retraction cord in place, a small one without any medication on it, very early in the sequence. The 801021 burr, this is probably the one that you haven't used much before. This is a round diamond. This is going to be used right after we break the contacts and put that first retraction cord in to actually prep the margin. And it's a round diamond, as you can see, and so when it's sunk to half of its depth, it's going to cut a perfect half circle in the gingival third of the tooth. That's going to do two things. It's going to assure we have enough reduction in the gingival third of the tooth, and it's going to cut our margin as a perfect half circle. That's going to be our prep margin, and when we do our axial reduction, we're going to be left with a quarter circle, which is, after all, the shape of the perfect chamfer or the shallow shoulder. It's either a deep chamfer or a shallow shoulder, however you want to look at it. Here's our depth cutting burrs that you'll see being used on the tooth a little bit later. We have a 0.6 millimeter depth cutter here that was used typically for our veneer techniques and still used for minimal prep veneer techniques to keep us within the enamel. And it's a very short depth cutter when we just want to get an idea of how much we're reducing on the tooth, but we don't use it in the crown and bridge technique that you'll see demonstrated here. I have it on here though because this is the one burr kit that I use for everything, regardless of it being cast gold, all ceramic PFMs. We have a 1.5 millimeter depth cutter here. And these are self-limiting depth cutters. You can see where the diamond is on the tip, and then there's a shelf right below it. And as you'll see on the video, when we actually push this depth cutter into the tooth, it stops. You cannot push this depth cutter in too deep. So when I was in dental school, we were taught to do these depth cuts with a 330 burr. But the problem with the 330 burr, at least in dental school, is if you push it too far, you're going to do an endo access. As we get older, we get better hand control, but it's still an issue of trying to determine if we've put it in the full 2 millimeters. So on this 2 millimeter depth cutter, for example, there's no way to put it in too deep. It simply stops at 2 millimeters. And the key part about that is that it allows you to do depth cuts efficiently. So you basically tape this depth cutter and you just slam it into the tooth and you've got a 2 millimeter hole, which allows us to be efficient. You can see maybe the 4 rings on the shank here. And each of those rings represents a half millimeter. So when you see the 4 rings, that's a 2 millimeter depth cutter. The burr that we do the majority of the work with is going to be our 856-025 super coarse grit burr. So once we've placed our depth cuts in, it's just kind of a race against time to see how quickly we can get all the enamel off the tooth. And this is our big workhorse burr, this 856-025. When you place depth cuts with these other burrs, but it's this burr that we're going to do probably 85% of the reduction with. If we're not prepping the adjacent teeth, if we're prepping a single unit crown, it's going to be tight interproximally. So we're going to use a burr that's the same shape as this burr. This is an 856, but it's a smaller burr. It's an 016 instead of the 025. So it's a much skinnier version of that same burr that we're doing most of our reduction with. And we're going to use this interproximally, just on the mesial and distal. Usually once we go through there a few times and create some additional space on the prep, we're able to go through with our 856-025 and take this all the way around the tooth, including interproximally. And then the last thing we need to do is the lingual reduction, the 379-023 football diamond. Again, in a super coarse, I like super coarse burrs because by virtue of the fact they remove more tooth structure, they create less pulpal heat, and they allow us to prep more efficiently. So that's all the burrs that are on the burr kit. To keep the cost down, I kept it at that amount of diamonds. There's actually one more diamond that I use. It's not on the kit. I often place it on the kit just separately. And that's this 856-025. It's the same as the other 856-025, except it's a fine grit, 30 micron diamond. And you can see the red stripe that's on there. And we take this burr at the very end, and because I have an electric handpiece, I turn the speed down to 5,000 RPMs. I turn the water off, and I use this burr along the gingival margin to smooth out everything. Because when you start to look at gingival margins under a microscope, there's lots of little chips out of there when you prep it just with the super coarse burr. So this is kind of over the top. This is because most of what I do is filmed and photographed. But it's also just gives a more accurate preparation and impression to the laboratory technician. It probably only takes 60 to 90 seconds to go around with this burr at the very end and smooth everything off. The days of needing mechanical retention to help our cement stay on the tooth are over. The resin reinforced glass ionomers we have today stick very strong to dentin, even dentin that's been smoothed with a fine grit burr like this. We get 6 to 10 megapascals of bond strength between those resin reinforced glass ionomers and the dentin tooth structure today. So there's really no reason to leave a tooth rough for cement retention anymore. So that's the reverse preparation kit. Let's go ahead and take a closer look at how it's used clinically.
We're going to be prepping a single anterior tooth here. The reverse preparation technique works just as well on posterior teeth as it does anterior teeth, but it's certainly easier to demonstrate these principles on an anterior tooth, tooth number 9, as we're doing here. You know, it can be shown on posterior teeth as well. All the same principles hold true, but it's just harder to see with the camera, and it's harder to put a mirror in and be able to see it as well. So for our purposes, we're going to do this on tooth number 9, but this certainly holds true in the anterior as well. Now, this isn't actually one of the steps of the reverse preparation technique, but the first thing we're going to do before these teeth dehydrate is to take a shade. And I'm going to use the VITA Easyshade Compact. I'm going to use it in the cervical third and the middle third. And I use this because it's never wrong. It always tells you what the closest shade is when you set it on the tooth. You know, we can still underprepare teeth, so the shade still won't come out right. There's lots of other things that can affect the shade. But the VITA Easyshade is never wrong. It tells you what the closest shade is in that spot. You know, you have to put it in a couple of different spots to make sure that you're getting, you know, not just hitting an anomaly, but it's never wrong. This is the PFG gel being placed into the sulcus on tooth number 9 with an Ultradent syringe and a mini infuser tip, and we're going to leave that in place for about 45 seconds and let that melt down into that sulcus to help anesthetize that sulcus. And we just want to be able to give as painless an injection as possible. We use the same anesthetic, the light version of it, the PFG light, when we're in the vestibule before an infiltration. But here we're going to do the single tooth anesthesia technique, and slowly I'm going to put a couple drops of anesthetic in the sulcus and then slowly penetrate the tip of the needle through the attachment and down to the bone. And with the combination of that super strong PFG gel, the patient's not going to feel that. And as it slowly gives the anesthetic, we're also going to get an audio and visual feedback. Take a look at our rapid anesthesia program if you want to see this, a full explanation of what we're doing here and how it works. But it's certainly a fantastic way to be able to anesthetize an anterior tooth like this without getting the patient's lip numb, without getting their nose numb. You know, infiltrations are typically pretty easy to tolerate as a patient until we get up to teeth number 7, 8, 9, and 10. And in people who are really sensitive, it's really tough to sneak a 30-gauge needle underneath their nose and then give a carpule of local anesthesia. So I'm a big fan of the single tooth anesthesia, the rapid anesthesia concept, as you'll see. This is an endodontically treated tooth, so it's not as big of a deal. But step 1, we're going to break the contacts. This is the first step of the reverse preparation technique. We've got a 56 carbide burr that we're taking in between here. And really all we want to do is create separation between tooth number 9 and tooth number 8 and 10 for step 2, where we're going to actually place the first of our retraction cords into this sulcus. Now, if this were a case where we're going to prep tooth number 8 and tooth number 9 at the same time, we'd be using a different burr and prepping both these teeth simultaneously. But because we're just doing a single tooth here, the ultimate aesthetic challenge for any dentist, we're using that 56 burr, and now we're going to take a double zero cord as step 2 of our technique and floss it in the mesial, and then we're going to floss it in on the distal, just like our dental floss. Nice and subgingival, I grab both ends on the lingual and pull to the lingual, and I leave this loose loop that you can see here on the facial. It's about the right length. I take my cord packer. I don't like serrated cord packers. They tend to pull the cord out on me as I'm trying to pack it in, and I don't like off-angle cord packers for the most part. I like short cord packers. I want my fingers as close to the action as possible. I hate those really long cord packers. Just too much, I don't know, distance for me between my fingertips and where I'm working. So a short, non-serrated, straight cord packer is what I like. That one happens to be from Hugh Freedy. Now, since that first cord's going to be in place for about 45 minutes, sometimes almost an hour, there's no medicaments on it of any kind because it's going to be in there for a long time. So there's no hemostatic agents of any sort. There's no epi cord in there as well. It's just a plain double zero hollow cord that's going to sit in place there and hold the tissue back throughout the rest of this procedure. And then we're going to trim it on the end and tuck that end down so it completely disappears, and then trim the other end and pack it down so both ends are flush. Step 3, preparation of the gingival margin. I told you it'd come early in the prep sequence, and here it is. This is an 801-021 burr from the reverse prep kit from Axis Dental, sold through all dental dealers that's being used here. And you can see we're tracing it around the gingival margin. Now that first cord we put in, that 00 cord, that Ultra Pack cord from Ultradent, is moving the tissue back about a 0.5 millimeter. So the tissue is being held back right now. So we're able to drop this down to the level of the free gingival margin. When we take that cord out, the tissue is going to rebound. And when that tissue rebounds, what we're going to end up with is a slightly subgingival margin without ever having to take a burr subgingival. And that's really important. When we do anterior restorative dentistry, we want to make sure, in the name of aesthetics, that we have a margin that is slightly subgingival. But we never want to have to take a burr subgingival, because that is going to destroy some tissue. It's going to cause bleeding. It's going to make it difficult to take a good impression. And so by putting that first hollow 00 cord in and leaving it in place throughout the entire technique, we're going to have that tissue retract and be able to work in the area of the gingiva. And it's going to end up being subgingival when that cord's removed, even though it's supragingival or equigingival right now. And you can see that we've got a nice C-shape that is formed on there. So basically, when you take a round burr and bury it halfway into the tooth, you're basically cutting half of a circle into the gingival margin. So this half circle, or this half ball shape from the round burr that we've cut into that tooth, when we do the rest of our axial reduction, we're going to end up with a quarter circle down at the gingival margin. And really, that is the perfect margin. That's the perfect heavy chamfer or shallow shoulder that we're trying to cut on these preparations. Step 4 is the incisal edge depth cut. This is the 2 millimeter depth cutter. We're taking 2 millimeters off this incisal edge because tooth number 9 is the same length as tooth number 8. And when we restore tooth number 9, we still want it to be the same length as tooth number 8. And so in order to get a good aesthetic incisal edge, we need 2 millimeters of depth cut there. If that tooth was 0.5 millimeter shorter, we would only have to do a 1.5 millimeter depth cut, and that burrs in the kit as well. But we're going to take 2 millimeters off to give our dental technician the best choice of giving us a nice, natural looking incisal edge. And it's really important to leave them 2 millimeters if that's what you expect from your technician. They cannot do it with 1 millimeter. 1.5 is even difficult sometimes unless you're going to lengthen the tooth. The next thing we need to do is our axial depth cut. This is step 5. So we're going to go right below that incisal edge depth cut, or just gingival to that incisal edge depth cut, and that's our 1.5 millimeter depth cut. And you can see we just push that into the tooth, and it bottoms out, and it does not go too deep. So you can see we've got all our depth cuts here. We've got the incisal edge 2 millimeter depth cuts. We got our 1.5 millimeter depth cut right there at the junction on the middle third and the incisal third. And then we've got our gingival depth cut that was provided by the round burr, and that's a nice depth cut because it's also got shape to it, a very desirable shape for this deep chamfer or this shallow shoulder that we need for most of our restorative choices, whether it's a PFM or an all ceramic. The manufacturers of these materials want us to have at least a millimeter of reduction at the gingival margin, and many dentists tend to underprepare this. I did it for 13 years. I underprepared that, and then I underimpressed it as well. I did not get a great impression of that area. So this is really what we're looking for, because when we spend a little time going a little bit slower at the beginning of the prep technique, this is going to pay big dividends because we're going to get to go faster in just a minute. But right now we've really identified where we need to reduce, and there's really no question anymore as to whether or not we've reduced enough. You know, one of the weird optical illusions in dentistry is as soon as you take a diamond to tooth structure and start to prep it, you can never really tell where you are anymore. You lose all your reference points once you break through the surface enamel with a diamond, and it's really difficult to tell how much you've reduced. In a prep sequence like this that's based on depth cuts, you're never lost. It's like having a road map. You know what that 2 millimeters is going to look like, because as soon as you reduce the incisal edge enough where you can't see those depth cuts anymore, you have 2 millimeters of incisal reduction. And sometimes where the 1.5 one is, you know, on a vital tooth or for whatever reason, you may, do it and say, well, it looks like I'm at 1.3. If I stick the perio probe in, there's just a little bit. I don't think I need to go the rest of the way. But at least you know where 1.5 millimeters is on the facial. At least you know where 2 millimeters is on the incisal edge. So that's the 856-025 burr. It's really the workhorse burr in the reverse preparation kit. We do most of our reduction, we do most of our blending of planes with it. We're going to do most of the finishing of the preparation with it as well. I really love large diameter burrs like this because they do not dive into the tooth. You can see here we're using a skinnier one. That's the 856-016 burr, and that's because we don't have enough separation between tooth number 9 and tooth number 10 just yet. So it's the same shape as the 856-025, but a smaller diameter. And so we're taking that interproximally when we're not preparing the adjacent tooth to be able to create enough room to go in there with the 856-025 burr. But you don't want to rush that burr, because if you use the 856-025 burr too soon, you'll either inadvertently prep the tooth next to it, or you'll end up having to over taper the preparation in that area to get it to fit. And we see a lot of preps that look like that. We call them teepee preps, where it looks like a Native American teepee. And it's typically from trying to use too large of a burr and too small of a splice, and so you have to tip it all the way over to make sure that you don't prep the adjacent tooth. And oddly enough, when you do that, you usually end up under prepping the gingival third of the tooth you're prepping at the same time and over preparing the incisal third, which is kind of crazy that you would over prep it in one area and under prep it in another, because you end up strangling the gingiva where you under prepped it and encroaching on the pulp chamber in the incisal third where you over prepped it. So there's the 856-025 burr. This is what I love about electric handpieces. I've got this only spinning at about 5,000 RPMs. That's pretty slow, and the water's turned off. And you can see how clean and how easy it is for me to dial in everything as I do this. I can see the margins. I can see the powder coming off. I can see what's left on the tooth, on the planes of the tooth. I can see sharp edges that I have. It really is nice to be able to turn the water off and not overheat the tooth. So we do this on vital teeth. This happens to be a non-vital tooth, so I could probably run it faster, but I just like the control. You have to be more deliberate, and you have to cut with more pressure at 5,000 RPM. And with a regular air turbine, you can't dial it in at a specific RPM like that. And even if you could, there's not enough torque to be able to cut like that. So we do our initial blending of the planes. Now we're on to step 7, the lingual surface reduction. You can see we've got the football burr, the 379-023 burr, and you'll notice we have not placed a depth cut on the lingual of this tooth. You could, if you wanted to. There's a 1 millimeter depth cutter in the burr kit, and you can place a 1 millimeter depth cut on the lingual if you want to. But typically on these anterior teeth like this, it really is easy to visualize when the patient bites together how much reduction we have on the lingual. But that's totally your call. If you want to place a depth cut there, it's probably a good idea. Step 8 is placement of the top cord. So our double zero cord's in place. Now this is a hollow cord, a 2 cord. It's a 2E Ultra Pack cord from Ultranet. And the little green strand that you see in there is the epi cord, and it's being packed into place. And again, I'm just very fastidious about a dry sulcus and no bleeding. So this is a pretty healthy case, except over between 9 and 10 where the gingiva was irritated from the composite that was in place. So the epi cord's going to come in handy there. I've always felt that if a patient is not bothered by the epinephrine in a local anesthetic injection, if they can tolerate that, they're okay with the epinephrine in a cord that's going to be in place and then taken out for about 8 minutes. And if they're not okay with epinephrine in the local anesthetic injection, then we're going to use plain cord here instead of epicord. But if I can use epicord, I do, because it's all about getting the best impression that we can. Once that cord's tucked all the way in and disappears, we're going to take another 856-025 burr. This is a red stripe burr. This is an F, a fine grit, a 30 micron diamond that we're using here, this red stripe burr. So again, the handpiece is set to 5,000 RPMs, the water's turned off, and we're just smoothing off all the rough areas of the prep. As I've started to use digital impressions and started to blow my preps up onto a 15-inch computer monitor, you can see how rough and chipped preparations are along the margin. So I love taking this smooth burr and being able to run it against the gingival margins and smooth everything off. By the way, since we put that 2 cord in, the tissue has gone back about another 0.5 millimeter, maybe a 1/4 millimeter. So You can use this opportunity on an endodontically treated tooth like this one to drop the margin just a little bit farther on the gingival. Since the gingiva has been pulled back by the cord, you can drop your tooth preparation margin down just a little bit farther, so you end up with a slightly more subgingival margin on the facial than you would otherwise, since we don't want the root showing through. After we finish cleaning up the tooth and smoothing everything off, we place the Anatomic Comprecap. Patient bites together on that. This is from Coltine Whale-Dent, available from all dental dealers. You can see it's a little moist. If it's dry, you might have a tendency to over-desiccate the tooth, and you tend to get these little cotton fibrils that kind of stick to the tooth when you remove it, which you don't see if it's nice and moist. So then you can dry the tooth off. And we're going to pull that top cord, and you can see we've got a nice open sulcus there. You can really only see that one angle. And watch when I squirt the impression material. You can see it just moving in front of where I was squirting it. And I'm going to go around in the other direction now with my impression tip. And usually where you come together, if there's any fluid in the sulcus as well, when you bring the two impression materials together, you'll see a pull right in that area. You'll see the fluid actually kind of squirted out. So we're going to go around several times here as I go back to that start point. There's once around, and then we're going to go around twice and 3 times, 4, 5, 6, almost too many to count there. But I've noticed that if you just go around once, you'll get inclusion of fluid at that area where the impression material comes back to where you started. So you want to go around at least 2 or 3 times. 5 or 6 probably isn't necessary like we did there, but 2 or 3 is fine. And then we're seating an anterior double arch tray. This is the one from Clinician's Choice, and you'd like to make sure on this tray when the patient bites together that all 4 cuspids are picked up in the impression, and they were. And as we look at this, you can see we've got a nice margin that you can see all the way around from the round burr. And the more important thing is we've got some impression material beyond the margin. And this is about 1 millimeter of impression material beyond the margin that represents an impression of the root surface of the tooth. And this is really important because this is going to help the aesthetics of the restoration, because our technicians are going to be able to see the emergence profile. They're going to be able to see some root structure beyond the margin itself. This is also critically important because now they know exactly where the margin ends, because they can see some tooth structure beyond the margin. So they know beyond any shadow of a doubt where the margin ends. And if you take an impression where the very edge of the impression is at the end of the margin, it's really kind of deceiving and difficult to tell, where the end of the margin truly is. So when you have a millimeter of impression material going beyond that margin down into the sulcus, it achieves 2 things. Your technician knows beyond any shadow of a doubt where the end of the margin is, and you stand a great chance of having an excellent and aesthetic restoration because they're able to nail the emergence profile for that crown. For posterior teeth, the reverse preparation sequence essentially follows the same steps. In this case, we're not preparing either of the adjacent teeth, so we're using a 57 carbide burr to break the contacts on the mesial and the distal of this molar. And then once the contacts have been broken and we've achieved separation between the teeth, we're going to place our first cord. This would be the 00 cord, and this is going to go into place. I will typically floss it in place on the mesial and distal by hand and then pack it to place with an instrument. We're showing you this on an illustration because it's much more effective just to show this on an illustration than it is by actually preparing it. The next step, of course, is the preparation of the gingival margin with our round burr, the 801021 burr. And again, the burr is being held as perpendicular to the long axis of the tooth as it can be, and then taken to half of its depth, the farthest it'll go in. And we cut our margin on the facial and the lingual. We're going to go ahead and make some depth cuts using the MADC burrs that you'll find in the reverse preparation kit. This is the one that has 4 rings on it, the MADC 2.0, the 2 millimeter depth cut burr. And you can see we're making sure that we hold the tip of the burr perpendicular to the tooth surface as we make these depth cuts in the top of the tooth. So we've got 1 in the central groove and then 1 in each of the cusp tips. This is the 3-band 1.5 millimeter MADC burr. We make our axial depth cuts with this. By the way, that gingival depth cut we've already made is 1.25 millimeters deep. And those are the recommended reductions that we'd like to have for any PFM or any all-ceramic crown as well. 2 millimeters on the occlusal surface, 1.5 millimeters on the axial surfaces, And by virtue of the use of the margin creation with the round burr, we've got a 1.25 millimeter one. In reality, we see under reduction by dentists in all these areas, and we really need to try to stick to these numbers to get back some functional aesthetic restorations. Here we're using a large burr. This just happens to be an 856-025, one of my favorite burrs, to connect all those depth cuts on the occlusal. And that's literally what we want to do, is make a swipe across and make sure we don't see any signs of the most apical part of those depth cuts after we've made that reduction. We're then using the 856-025 to blend our axial depth cuts. At this point, I really try to cut these walls straight up and down. I don't try to get any taper in here. I want to cut it straight up and down, because as I move along the prep technique and blend these axial planes a little bit further, I'll get the correct taper. So in my mind, I really want to cut this prep straight up and down, or maybe even undercut it a little at this point. Anytime we cut with a burr in opposing planes like this, we're going to end up with some sharp edges. Here we're using a 3M SB Soft Flex disc to remove those sharp edges. Very important to get restorations back that fit, that we remove those sharp edges. Here's placement of the second cord. This is a size 2 cord from Ultradent being put into place on top of the 00 cord being packed down. The 00 cord, as long as it stays in contact with the base of the sulcus, when we pull that top cord, we will not have any bleeding. Very important that we put a Comprecap on top of this preparation once both the cords are in. This is an anatomical Comprecap with the little cutouts in the interproximal areas. We're going to place this over the prepared tooth. The patient's going to bite down on this for 8 to 10 minutes. And by using this 2-cord technique with the Comprecaps, I can honestly tell you that we have bleeding when we take an impression maybe 1 out of every 20 times, and that's typically pretty minor.